4th, 2021, COVID-19 clinical rounds, critical care. This one's on cognitive brain dysfunction, brain fog. My name is Richard Hunt. I'm an emergency physician who serves as senior medical advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer real-time sharing of COVID-19 clinical challenges and successes. If I'm a clinician caring for COVID patients, the clinicians I want to learn from are those with the most experience. This is a voluntary public-private collaboration. Thanks to the multiple professional organizations who are collaborating on these rounds. We especially appreciate those in critical care who take their time away from the bedside to be able to actually participate. These rounds are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience rather than recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges with other clinicians. Thanks to the National Emerging Special Pathogen Training and Education Center, NETEC, for their support with these rounds. NETEC's webinars complement these Project ECHO COVID-19 clinical rounds. Thanks to Dr. Struminger and Project ECHO for their support with the platform that we use for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. Mondays are EMS, Tuesdays are critical care, Thursdays are emergency department. This coming Thursday's rounds will be on lessons from the Mass Vaccination Site Collaborative. Last week, COVID-19 clinical rounds was on vacation. We hope you too took a break. The schedule for next week will be a bit different, actually importantly different. We will incorporate the usual EMS, critical care, and emergency department rounds into a single COVID-19 clinical grand rounds. We'll replace the usual schedule with the single grand rounds on the National Special Pathogen System, the Path Forward. That will be held in this slot Tuesday, but May 11th, next week's Tuesday slot, May 11th at US noon Eastern time, just like usual. I'll now turn this over to Dr. Struminger for some logistics.
Great, thank you, Rick, and welcome everyone. Thanks again for taking time out to join us for today's really important topic focused on post-COVID syndrome and brain neurologic issues. Just going to quickly run through our usual logistic items. Most important, we really appreciate your questions and comments. That's what helps keep these clinical rounds interactive and optimally engaging. So please put those in the Q&A feature. If you have any technical or logistic issues, please mention those in the chat and we'll try to help you as best we can. We're recording today's session as we always do, and your attendance is consent to be recorded. Thank you for that. Today's presentations will be shared after today's session, along with the recording on our website that supports the clinical rounds, and we'll share a link to that, and they should be up within a day or two. We are offering CME and continuing professional development credits through the University of New Mexico, where Project ECHO is based. We'll share a link to the post-session evaluation, which links directly to the instant CME and CPD. And you'll have 48 hours to complete that. It should only take 2 or 3 minutes, and we really, really appreciate the feedback you give us so we can continue to improve these and plan for new topics. And we really appreciate that. So take advantage of that, whether you need the CME or not. Just a reminder that these learning sessions are focused on improving patient care and health systems and supporting clinicians. Please, let's continue to keep them apolitical and non-commercial. Thanks for that. You've done a great job with that. Just a word about data use. We take data stewardship very seriously, and your individual data is all kept confidential. What we share with Rick and Asper is all de-identified, And so thank you for that. Rick mentioned that NETech is a partner and has been since the beginning of these clinical rounds in March 2020, over a year ago. They have their own great webinar series, and they have a session coming up tomorrow, Wednesday, May 5th, and it's on variants of concern, learning from experiences in the UK and Germany. That should be a great session, and we'll share a link to registration for that in the chat. Also, the American Association of Medical Colleges is a partner in the Clinical Rounds initiative. They have been collaborating since last March as well, and they have their own fabulous clinical guidance repository that they update on a weekly basis, and we'll share a link to that. It's a great resource. With that, Rick, back to you for today's crowdsourcing question.
Yeah, thanks, Bruce. Today's crowdsourcing question pertinent to the topic: how is your organization supporting the care of patients with COVID-19 cognitive brain dysfunction or brain fog? I do want to mention really quickly that, in quotes, brain fog. That term, you know, it's like the long haul patients. Certainly not meant to be derogatory in any way whatsoever, but is a term self-described by quite a few patients that have this challenge with functioning after COVID. So I just want to note that and say that out loud. I'm now going to turn this over to Dr. Jeff Dichter, Associate Professor of Medicine at the University of Minnesota, and also Executive Committee member of the Task Force for Mass Critical Care. And their members, and Jeff and his leadership has really been supportive of co-sponsoring our rounds on Tuesdays for critical care over the past few months, and much appreciated. Jeff, turn it over to you now. Thanks.
Thank you, Rick, and thank you, Bruce. Appreciate it. Can everybody hear me okay? Can everybody hear me okay? Let me take a look here. Rick, can you hear me?
Loud and clear, Jeff. Loud and clear. We can see.
Okay,
you might not be able to see us, but there were a lot of thumbs that went up and said, "Yeah, we can hear you." So we're good.
I appreciate that. I had lost my audio right before we started and had to regroup, and so I just wanted to be sure it was still working. Good morning to everybody. Good afternoon to those on the East Coast and further east. I'm really excited about the session that we have planned for this afternoon. It's COVID-19 effects on cognitive brain function. And two wonderful presenters and several really experienced panelists. So our two presenters are Dr. Nihat Dangayich from Mount Sinai Health System, the Econ School of Medicine, from the Department of Neurology and Neurosurgery. So thank you. We are good friends, and I appreciate having her. And Dr. Karen Blackman from the Mayo Clinic in Florida, Department of Psychiatry and Psychology. So really grateful to both of you for being here, presenters. Our panelists who we've heard from before, Dr. Whiteside, Dr. Morse, Dr. Ganesh, Dr. Wong, Dr. Sharon, Dr. Melnick, and also Dr. Raymond Razamal. So with that, Nihat, we'll go ahead and start with you and go from there. Thank you.
Thank you so much for the opportunity, and it's my honor and privilege to present as part of Project ECHO's clinical rounds. And I'm going to be talking about brain fog in COVID-19, and specifically, before I jump into my slides, I would like to acknowledge a lot of the wisdom that I've gained from being a part of the CHESS COVID-19 task force that Jeff and I serve on together. And also faculty for the Stop Virus Collaborative, which is a collaboration between SCCM and CDC. So the objective of my talks are going to be to learn a little bit more about brain fog, this post-acute sequelae of COVID or PASC, lots of different terms being used to describe the symptoms that our patients suffer from after the acute phase of COVID-19. And then we'll also talk about some insights about similarities and differences between PASC, PICS, and chronic fatigue syndrome, and similar other syndromes. So let me start with a story from Dr. Sondra Crosby. She's a professor at BU, and she published her experience with COVID-19 in the Annals of Internal Medicine earlier in 2021. She said her brain wasn't functioning at 100% and she was still finding herself with different kinds of lapses. She couldn't find her passwords. She had difficulty remembering her DA number. It was as if her brain had been completely taken over by COVID-19. And she mentions that since we don't know the long-term effects, she doesn't know when she's going to recover. But as a human being and as a healer, she's keeping her eyes on the horizon so that we can continue finding solutions for what COVID-19 entails for our patients. The press has given a lot of importance to this syndrome, and rightfully so, because millions of our COVID-19 survivors are not being able to go back to being the people they were before they had COVID-19. And why is this happening? And that's been an ongoing challenge for us as clinicians, researchers, and scientists. So let's take a quick pause to think about the pathophysiology of different kinds of neurological manifestations. I won't belabor this because I know there was a recent session talking about the overall neurological manifestations of COVID-19. But if we were to really simplify why COVID-19 affects the brain, both in the brain and the nervous system at large, in the acute phase as well as the longitudinal phase, we can think of it as being the effects of direct viral invasion, the endotheliopathy that comes with COVID-19, activation of the coagulation cascade, this inflammation that really gets dysregulated, and then neurocytotoxic effects leading to both acute as well as longitudinal neuropsychiatric symptoms, including what's being described as brain fog or difficulties in memory, processing speed, multitasking, etc. So as the spectrum of neurological manifestations can be thought of as being very wide, depending upon how we think of these symptoms, either by way of the type of injury, anatomically, the pathophysiological phase, are these symptoms occurring during the viremic phase, the coagulopathic phase, endotheliopathy, the time course as being acute, subacute, or chronic or longitudinal, or just based on the severity of COVID-19. And I won't go into each and every of different kind of manifestation, but all of these different things have been described in literature. And the purpose of this presentation is to really try to drill down on PASC and brain fog. So let's take a quick peek at the timeline for what post-acute sequelae of COVID could look like. So we think of acute COVID as the disease symptoms ranging from being the asymptomatic phase right up till 4 weeks or so as being acute COVID. And then we think about post-acute COVID-19 as this subacute ongoing COVID, where COVID-19 hasn't completely resolved up to week 12. And then the symptoms that continue beyond week 12 can be thought of as chronic or post-COVID-19. In this recent review that was published in Nature Medicine, the authors did a really nice job of summarizing this complex literature of this multi-system involvement of COVID-19, both in the acute phase as well as this post-acute or chronic phase of COVID-19. And specifically, when we think about the neuropsychiatric manifestations, it's important to screen for anxiety, depression, PTSD, sleep disturbances, cognitive impairment, which includes executive functioning, memory problems, problems with multitasking, etc. In terms of literature, I would point you to the IDSA's blogs that they've been maintaining, some key literature. There's thousands of papers right now on just the neurological manifestations of COVID-19. So just trying to keep this literature straight is difficult, just like rest of COVID-19. But the IDSA has done a nice job of collating some of this literature and also putting it into the context of how this literature is evolving. And similarly for PASC or post-acute COVID. With respect to the symptoms, I will specify that thinking of brain fog in isolation as just being cognitive issues may perhaps not be the right way of thinking about these symptoms, because these patients are going to have a continuum of symptoms. They may suffer from depression, anxiety, PTSD, as well as these cognitive issues, either as a consequence of the cognitive issues themselves, or these symptoms may just coexist. What's being described in studies that are looking at both retrospective as well as prospective cohorts, about 20 to 40% survivors can suffer from depression and anxiety. about a third can suffer from PTSD, and about a third or so can suffer from cognitive issues. A little lesser is known about cognitive issues as compared to the behavioral or psychiatric manifestations, both in the acute phase as well as the longitudinal phase. Some key risk factors or risk factors that may predispose patients to developing these symptoms include females, younger age, being critically ill, having a past psychiatric history, and all of those other risk factors that we now know are associated with more moderate to severe manifestations of COVID-19, right, from BMI, diabetes, obesity, etc., have also been associated with these neuropsychiatric manifestations. Now I'm going to talk about a framework that we're currently thinking through. Several other authors have also described this in literature. There are similarities between these pre-COVID-19 syndromes that our patients have suffered from. For example, this post-viral myeloencephalitis, myalgia encephalitis, and chronic fatigue syndrome, PASC or long COVID, post-intensive care syndrome, as well as chemo brain. And in terms of the timeline, both the NICE guidelines as well as how we're thinking about it with respect to the NIH's definition of PASC, there is that similarity. Well, for symptoms that are persisting beyond 12 weeks or so, we're referring to them as post-acute COVID sequelae. So for post-intensive care syndrome, for an audience that has several critical care providers, I don't need to belabor this, but different domains of physical domain, cognitive domain, and psychiatric domain, and these are the unintended consequences of critical care that have been described. First, this framework was first proposed as part of a stakeholder conference in 2010. And since then, we know more than 50% of our ICU survivors are going to suffer from PICS, particularly after ARDS and septic shock. In the seminal paper that looked at the cognitive impairment that comes after surviving ARDS and septic shock, including patients specifically including patients who did not have pre-existing cognitive impairment, patients at 3 months and 12 months, both younger and older patients, suffered from a mild cognitive impairment, or their cognitive scores were even closer to, particularly for the older patients, closer to patients who have mild Alzheimer's disease. In our recent experience that we described for COVID-19 ICU survivors, about 91% of the patients we followed in our critical care recovery clinic met the criteria for PICS. And we found only 8% patients had impairments on cognitive screening, but it really makes me wonder if this was because of the screening tool that we were using. We were using the telephonic interview for cognitive status. Perhaps the MOCA might be a better cognitive assessment screen, but that needs to be studied further. Specifically with respect to chemo brain, this has been well described in literature, lots of reasons why patients who've received chemotherapeutic agents can suffer from symptoms that are similar to what we're hearing from patients with brain fog. Again, there might be neuroinflammation as the unifying hypothesis for why this may be happening. And for ME/CFS syndromes, a lot of different viruses have been described as causing chronic fatigue syndrome. And again, neuroinflammation and longitudinal effects of the virus may be of the original virus, and this antigen mimicry may be responsible for why patients suffer from longitudinal consequences. However, despite all these similarities, there are key differences between post-acute sequelae of COVID-19, and it is important to really hone in on international collaboration, longitudinally following these patients to develop targeted treatments. Some common principles, of course, bearing in mind that when patients with COVID-19 are describing worsening or new onset neuropsychiatric symptoms, this could either be because of COVID-19 itself or because of the pandemic-related stressors. Patients who have pre-existing psychiatric or neurological problems will be at a higher risk of developing some of these consequences. Using longitudinal screening tools, well-validated screening tools, for ensuring that these patients don't get misdiagnosed or these diagnoses don't get missed and they get the appropriate care that they need, and then providing care in a highly coordinated fashion, particularly leveraging telehealth wherever possible to link these patients up with all the different resources that they need. Just a quick snapshot of some of the ongoing clinical trials that are trying to look for targeted treatments for COVID-19. These are ongoing, including pharmacological interventions as well as mind-body interventions. So with that, I'd like to stop, and I'd like to say thank you to all the patients and families that we've had the opportunity to work with throughout this pandemic. And here's my contact information, and I'd be happy to take questions during our Q&A. Thank you.
Thank you, Neha. Thank you. That was really good presentation. Thank you. And we'll go ahead and go to discussion, but we're going to have Dr. Blackman. We'll go ahead and have Dr. Blackman do her presentation next. Karen, go ahead.
Thank you, Dr. Dangayash. That was a just beautiful presentation. I'm going to try to not be redundant, because some of the things you presented, I'll be directly referencing. And what I hope to get us thinking about is what to do with these patients, how to zoom in more on the cognitive screening measures so that we can develop some care flow pathways and direct patients to the appropriate level of follow-up, diagnostics, and interventions. So thank you for giving me the chance to talk about how we've been tracking and targeting neurocognitive sequelae of COVID-19 here at Mayo Clinic in Florida. By now, we've all seen these patients who are coming in with a range of complaints. As Dr. Dangayash already presented so beautifully that case study, but I've seen quite a few now of young people who are unable to work as effectively, return to school, complete school assignments, people in their 20s, 30s, and 40s who want to get back to work but are facing some severe obstacles, feeling very forgetful. They can't seem to focus. They have no energy, the chronic fatigue, feeling anxious all the time. And although some of this may predate COVID, a lot of it was then exacerbated by COVID. And these are patients that may come from hospitalized severe infections, or may have also just had mild infections and been quarantining at home alone. So what we're thinking about is how to stratify these patients based off of cognitive screening measures and develop care flow pathways to appropriately direct them. So in terms of the different cognitive profiles that have been reported in the literature, it's very heterogeneous, but there are some common themes. We are thinking about more of a dysexecutive syndrome, which involves frontal systems dysfunction, problems with planning, organizing, multitasking. I've had patients tell me they just stare at their email and they can't remember how to approach even something as simple as responding to emails in their normal workday, and they have to think about it explicitly, what used to be implicit. Patients who have impairment with sustained attention, they simply can't listen to a lecture for longer than 10 minutes. So these are students who are falling behind in their online. It could be because they've switched to online classes, but are facing some significant obstacles. We've also seen reports of patients with focal impairment in memory or language functions or attention functions that would point to some neurobiologic substrates. But we also know, because of high rates of PTSD and depression and anxiety, that may account for some of the variability in attention and executive dysfunction that we're seeing as well. So how do we start to pull apart the patients who might benefit from a more targeted psychiatric approach? So addressing some of their elevated anxiety and depression, getting that under control, and hopefully seeing some improvement in their cognitive status from those patients who may have more of a neurobiological substrate and need an intense neurologic workup with a range of imaging to try to better understand the substrates for their cognitive dysfunction. Now, we know that there will be a substate that do have neurobiologic substrate factors that are contributing. And I don't want to belabor this too much because I'm sure you've talked about it at length in prior sessions, but there are increased risk of intracranial and ischemic stroke, or sorry, hemorrhagic and ischemic stroke that might lead to focal cognitive signs. We know that there might be immune system dysregulation or hyperinflammatory syndromes, ARDS with hypoxia, and all of that could lead to focal amnestic syndromes, so more persistent damage to hippocampal mesiotemporal systems supporting memory. And we know that there are patients who might have more peripheral neurologic problems like Guillain-Barré, although there's smaller incidence of that, or small vessel neuropathy that could lead to dysautonomia, and they may need a very different approach. And of course, as a clinical neuropsychologist, we're very interested here in patients that are appearing with some suspicion of unmasking or an exacerbation of a pre-existing incipient dementia process, like a tauopathy or a synucleopathy or vasculopathy that may have been exacerbated by possibly a hyperinflammatory syndrome, or lesser evidence, it seems to be for direct viral infection. So are there any imaging parameters that have been linked directly to the cognitive symptoms that are being reported? There's just been a few studies. So a lot more work needs to be done so that we know what type of imaging to do to help point to changes or to neurobiologic substrates for these symptoms. So there have been studies that show increased levels of C-reactive proteins associated with attention deficits. There's been some studies that show metabolic glucose abnormalities in bilateral cerebellar regions in patients with cognitive complaints. And there's even been studies to show that some improvement in the hypometabolism of patients associated with improvement in their cognitive test scores. And that's very small samples. And so this is extremely preliminary, but just to get a hold of what do we know, is there some genuine neurobiologic substrate for these symptoms in the subset of patients? So when it comes to cognitive screening, we think about a three-pronged approach. And this has been not just me, but a large group of neuropsychologists who want to harmonize an approach across multiple centers and hospitals to figure out how do we assess, where do we screen, and who should get a full neuropsychological eval, which we all know is very much more extensive and costly for patients. So it's important to think about these different stages and what they entail. At the acute stage, which would be hopefully right before discharge if a patient has been hospitalized with severe COVID. And that's important for being able to document whether an encephalopathic process or delirium was present, because we know that's a strong predictor of post or long-term cognitive outcomes. So something as simple as a Glasgow Coma Scale, or using the confusion assessment method, or even a 30-point MoCA, which can be administered through hospital InTouch telemedicine platform, or even over the phone. There's a modified 22-point blind MoCA. So to collect that data before discharge, again, to be able to inform long-term outcomes. At stage 2, what we've been doing is administering a 30 to 40 minute computerized test battery for patients in hopes of stratifying those into patients who show objective neurocognitive signs versus those who have high symptom report but are performing normally on objective measures. So we're using the CNS vital signs for that, which is a 30-minute computerized testing platform, and it includes performance validity measures, which we know are very important if patients are sitting by themselves doing computerized testing. We need to have some validity measures built in. And it also has normative samples that were collected prior to COVID. So we have some sort of comparison group to be able to detect mild, moderate, and severe levels of cognitive impairment. And it also benefits from having a large item, so we can present random stimuli at each serial assessment. We also administer questionnaires to be able to pull out self-reported mood, anxiety, fatigue, and possibly suicidality that would warrant appropriate follow-up. And of course, PTSD, which we know is there's increased risk in this population. So then the stage 3, the full neuropsych eval, would be a much more comprehensive 2 to 4 hour assessment, which could involve a hybrid model of telemedicine and in-person with PPE. And that's really essential for being able to make targeted recommendations for patients to be able to return to work. And that will be able to measure the full range and severity of the PASC symptoms, and to assess their premorbid status, any comorbid possible dementia, pre-existing Parkinson's that may have been in place, or dementia processes, or comorbid psychiatric disorders that could exacerbate the symptoms, and also the sociodemographics. In the full neuropsychological evaluation, we have the benefit of selecting norms that are appropriate for that patient to have a much more sensitive and detection of and characterization of their neurocognitive syndrome. And of course, validity measures and more targeted assessments of their function and activities of daily living to, again, have better recommendations for rehab. So just to speak very quickly about an approach we've taken with about 150 patients who we've administered these test batteries. And I want to point out that in patients who have more severe COVID, we are already seeing a greater incidence of objective cognitive impairment, pointing to focal cognitive signs such as visual memory impairment or processing speed compared to patients with a more mild syndrome. And what that says to us, although patients may have an increased, let's say, cognitive processing speed problems in even ambulatory or mild COVID patients, that may be more increased compared to non-COVID patients, but it's not as severe as in patients that were hospitalized, that the base rates are higher in the hospitalized patients. So that points to a different care pathway for patients who have possibly had a more severe syndrome and are showing more objective cognitive impairment. However, we did not see any difference between the ambulatory and the hospitalized patients on the self-report measures. And so, sorry for this busy slide, but just to call your attention to the cognitive symptoms, we see similar rates of self-reported attention and memory problems in patients that were hospitalized or ambulatory, although their objective testing does show a difference. So the point there is that patients, there may be a subset that are reporting high degrees of attention and memory problems, but yet on objective testing, they're performing within normal limits. And we want to treat those patients differently before referring them to a full neuropsychological eval. We'd like to have a screen to point to those, to pull out those patients that may not actually need a more comprehensive and costly evaluation. So this is our proposed care pathway, and this is in the works. I know a lot of places are setting up their post-COVID care clinics and trying to think through this. So your input and your thoughts are very welcome. So here we're thinking about patients that have the cognitive complaints. They go to the post-COVID care clinic. They have their neurocognitive screen, which may involve a MoCA or the CNS vital signs, as I pointed out, that was a measure we're using. And they also get subjective questionnaires of their cognitive mood state, fatigue, sleep, and psychiatric symptoms. And what we ask is that, are there objective neuropsych signs present? If not, we ask, are there subjective neuropsych signs present? And if so, we may refer them directly to our 2-day chronic fatigue syndrome program that's actually currently being modified for post-COVID patients. And they may not need the full neuropsychological assessment, although they do need some support and help in being able to get back to their baseline level of functioning. And if no subjective or objective signs are present, maybe then they don't need any further intervention from a cognitive standpoint. However, if objective neuropsych signs are present, they would benefit from the full neuropsychological eval to make targeted recommendations for rehabilitation, again, to get them back to work and back to school. So that's our general thinking about a cognitive care pathway. In terms of psychiatric, just a little bit more thinking about who would benefit from a psychiatric consult to target the anxiety, depression, and possible suicidality to determine whether once that's under control, some of their cognitive symptoms may in fact resolve. So that would be the thinking to guide us. If a patient is reporting severe psychiatric symptoms or PTSD, they may benefit from a direct psychiatry consult. And that at that point, the psychiatrist may think they would benefit still from the 2-day chronic fatigue syndrome program, or some patients maybe who are less moderate to severe symptoms might benefit from going directly to the 2-day program. So again, just to get us thinking about these decision pathways, I'd love to hear your input. Thank you. I didn't put my usual thank you slide up for all of my partners here who are thinking through this very carefully and trying to make decisions about setting up the most appropriate levels of care for these patients. So thank you.
Thank you. Excuse me. Thank you, Karen. That was really, really interesting. And both of you, you know, the biology and the functional. So if there are questions from our panelists who would like to go ahead and ask, I guess one of the questions I have, which I'll, excuse me, which I wanted to ask, is there's a lot of different ways you assess these patients. I guess from just a more simplistic question, and Karen, I guess I'll ask you and Neha, when somebody walks in and you do an assessment, I mean, what are you able to give them some kind of direction based on just one assessment, excuse me, as to how they're going to do? What kind of reaffirmation can give them a reassurance? I mean, what can you tell somebody when they walk in? I guess it's reassuring and give some kind of prognosis for them early on.
Karen, do you want to get started? That was an excellent presentation from you. And then I can chime in after.
Thank you. I was hoping you would answer, because I feel at this point, I'm reading the papers as they come out in hopes of giving patients a better idea of what's to come, but it's still so difficult to say. I will tell you, I'm very excited to have this program now in place for patients, this 2-day program, because I get the sense from a lot of them that they're experiencing real functionally limiting symptoms. And they need some guidance and from a cognitive rehab standpoint of how best to organize their day-to-day life to gain a sense of control back, which will reduce their anxiety level, hopefully improve their sleep, and we start to see this cascade of effects. So my view, and I'm giving them some hope when this program is off the ground by saying, let's try this program. Let's see if that gets you on the right path. Sleeping better, less anxiety, greater sense of control over your day-to-day life, because a lot of this catastrophic thinking is holding patients back. They've been trained through this whole pandemic to treat every somatic signal coming from their body and every negative thought as a threat. And that puts them in this state of chronic anxiety. So by going through a program that teaches them not every signal, not every thought is a genuine threat, they can start to slowly inoculate themselves to these signals that are coming and hopefully function at a better level.
And to just add a few things to what Karen said, validating people's concerns, because early on in the pandemic, so I'm from New York, and our first wave was really overwhelming, and understanding what was going to happen to our survivors. Of course, we were all very cognizant of the fact that we will need to start putting together resources for taking care of some of our COVID-19 survivors. And what is the magnitude of these longitudinal symptoms going to be? We're still trying to figure out how much it's going to affect patients and for how long. Having said that, a couple of things that I think are important for us to take a step back and understand how to pivot some of the pre-existing resources. So as an intensivist, the whole idea about post-intensive care syndrome and having critical care recovery programs, which are multidisciplinary, and making sure that we're coordinating patients' care so that our survivors don't slip through the cracks and are able to avail of all the different resources that they need. So providing them, setting the right expectations that yes, you've survived COVID-19, but you're going to potentially suffer from some of these unintended longitudinal effects, both of the treatments that you have received after you've been hospitalized, either on the floors or in the ICU. And for those patients who have been self-quarantining at home, also preparing them to watch out, look for, these are the things that you should be watching for. And if you start suffering from these, it's not just all in your head. These are real, and it's happening to a lot of other patients across the world. In terms of our local approach at Mount Sinai, we have 3 different programs right now for COVID-19 survivors. One of them is a precision recovery program for those patients who are not sick enough to get hospitalized. So essentially, they all enroll in this app, and they're doing some monitoring of their symptoms at home and daily entering their symptom log. It's fairly comprehensive, including some physiological signs like heart rate, blood pressure, your O2 saturation, etc. And these patients remain in the program for as long as they would want to stay in the program, and they're connected to cognitive, physical therapy, occupational therapy specialists. The other program is our critical care recovery program. So we run this critical care recovery clinic. We have spiritual care, physiatry, intensivists, social work, case management, and we loop in other consultants as needed. This was meant for both COVID-19 and non-COVID-19 survivors. So we're actively screening patients. So we're letting them know that you are going to potentially suffer from PICS, as well as some of these other symptoms of COVID-19. And then there is this bigger COVID-19 center that was a multi-specialty center that's coordinated by the Department of Medicine that brings together some of the different departments that Karen mentioned, including neurology, rheumatology, cardiology, so on and so forth, making sure that we don't duplicate our efforts. And a lot of these patients also suffer from chronic medical conditions, which might get exacerbated because of COVID-19, because they haven't been following their regular regimens, or there are financial hardships, and now they don't have their medications, etc. So making sure they have like a one-stop shop at a COVID-19 center, which is going to take care of their COVID-19 longitudinal symptoms as well as their chronic medical conditions. Sorry, Jeff, but there wasn't one single screening tool. I think it's going to take a village. This is a lot.
I appreciate that. And there was Dr. Hunt had a note here too in the chat session. Just I know, and yes, apparently in the session yesterday, some concern about teens and anxiety being, post-COVID being related to anxiety. Do you have any comments on or any experience with that?
Well, when it comes to anxiety, yes, I've given this one a great deal of thought because so many of our participants are struggling with elevated anxiety. And so just coming back to something I referenced earlier that is targeted in our chronic fatigue syndrome is that it's a learned mechanism that through all of this pandemic, we've all learned to pay close attention to signals from our body. And that is a genuine sign that something is going wrong. And so with that learning over time, that attention to these signals as a source of threat, we then become very anxious when we experience anything. And so there's this learning process that goes on. And then when patients then it's reinforced by real symptoms, and then they're told this is positive, then it strengthens that learning pathway. And so it takes some therapy and deconditioning to then actually go back and say, wait a second, not all of those signals are bad. You don't have to be in a chronic state of threat anxiety all the time because that impairs their sleep. They are unable to sleep with everything they feel if they think something's going wrong. So their body's in a chronic state of fight or flight. So someone had asked about alternative methods, and a lot of the COVID programs do use good old cognitive behavioral strategies, like not misinterpreting or catastrophizing internal or external information, so our own thoughts or signals from our body, but also just behavioral methods of using calming strategies at night, challenging maladaptive thoughts. But this is hard because everything in the media and including their healthcare are saying, well, these are actually important signals and you should be worried if you have this. So it's very confusing for patients. And I think until we can start to feel a greater sense of control as a healthcare professionals, then we can model that and show them actually it's okay, things will be all right, we'll get past this, and not every signal is a sign that something really bad is going to happen.
If I could just bounce off of what Karen said, I would also not minimize the role of mood. In fact, we're actually finding stronger correlations in our data between mood and cognitive difficulties in the post-COVID patients. So anxiety definitely, but the mood, which is related to anxiety as well, but both premorbid and comorbid mood disorders, particularly depression, are also playing a role. And when that's where you get to some of the same phenomena like the catastrophic thinking, those sorts of things. So, our program is a little different than the Mayo program, but we have health psychologists who are basically working with these folks with the same sorts of approaches, which I think is really a critical part for some of the long COVID patients.
Harry, do you have a question?
Yeah, thanks, Jeff. And first, great presentations and very timely, as has been noted in the chat. Really important as we're making that turn from just treating acute COVID to recognizing the societal burden of this more chronic issues. I have two questions, one specifically for Neha and the other probably for both of you. Have you noticed a correlation between the severity of the acute COVID phase to either the longevity or the severeness of the cognitive issues chronically, or can the folks that have milder acute cases of COVID have that same chronicity and severity of neurocognitive symptoms? That's my question directly for you. And then to both of you, for us who are non-neuropsych professionals, as we see those patients come into our practices or into the emergency department and we seek referral, do you have any suggestions on how to decide which pathway? Do they need psychiatric referral first? Do they need neurologic referral? Do you, if you're not in a center of excellence where you can refer them into your post-acute COVID clinic. So I'll take those answers offline, and thank you again.
Thank you, Harry. So to answer the first question, what's been most perplexing about COVID-19? So on one end of the spectrum, you have these patients with moderate to severe COVID-19 who've been hospitalized. The severe COVID-19 have been critically ill, and all those consequences that you can expect in patients who have critical illness, ARDS, septic shock, multi-organ system failure, all the medications, prolonged use of different kinds of sedatives, not moving, delirium, all of those things that we knew of in the COVID-19 era that led to a higher incidence of post-intensive care syndrome in these patients, all apply to COVID-19 as well. Now, to that, we can add a milieu of those symptoms that seem to be a little more specific for COVID-19, including the POTS, or the orthostatic tachycardia syndrome, the postural orthostatic tachycardia syndrome, or some other dysautonomic features which may not always be seen in patients with PICS from non-COVID-19 causes. So on one end of the spectrum, you're expecting patients who have survived severe COVID-19 illness to have some of these PICS type symptomatology. And then there are those patients who had been quarantining at home, who had mild symptoms from COVID-19, but then developed these in the post-acute COVID phase beyond 12 weeks or so. They're continuing to suffer from cognitive problems, behavioral problems, autonomic problems. Why is that happening? And understanding, if we said this was all related to the viral loads, then the patients who had severe COVID-19 there should be like a direct linear correlation between what's happening to patients with their COVID severity and the severity of the symptoms that they suffer from as part of their PASC, but that's not happening. Then what else is going on? Is it this antigen mimicry? Is it because of this dysregulated activation of this inflammatory cascade? Is it mast cell activation, microglial activation, and this longitudinal activation that remains in place, particularly for patients who are predisposed to developing autoimmune problems? For example, women, people who are in their 40s and 50s, who have a genetic predisposition, etc. So I think there's a lot to unpack and process about why patients with mild to asymptomatic COVID-19 perhaps have a more severe manifestation of PASC, and patients who had severe or moderate to severe COVID-19 acute illness don't end up having the same magnitude of some of these symptoms. So I don't think we completely understand that yet, but I'd love to hear from some of the other panelists and Karen about your thoughts.
Well, in our data, it did show that the severity of COVID was predictive of greater objective cognitive impairment, but not greater subjective. And that was the key difference, is that patients are experiencing severe cognitive symptoms, but it's discrepant from their actual performance. So we have to think about those two things differently and measure them accordingly. And that's what I was hoping to get at with the care flow pathways, that it's important to have both objective and subjective measures to be able to pull that apart. Because then you start, when patients are relying on self-report, it becomes then very difficult to disentangle that from their own anxiety, mood state, and biases that that entails.
Karen, so I had a case that I saw that kind of illustrates this point very well. Not long ago, it was a patient who happened to have had a previous neuropsych eval in 2014 by one of my colleagues for kind of general memory complaints. Turned out the report concluded that she had some very subtle things, more inefficiencies related to mostly depression, and then developed COVID. And I saw her, and she reported a number of really serious problems cognitively, and she said that these all got worse after COVID. And so she was one of these people that Karen's referring to about, a lot of cognitive complaints. But when we did objective testing, and I had the benefit of 2014 testing, she actually stayed the same or improved on every measure but one out of a battery. So there's a real disconnect between the subjective experience and the objective test data that we have. But what was but was even higher when I saw her than in 2014 were the depression and anxiety measures, which were high in 2014 and were astronomical when I saw her. So there's definitely a piece, and I think it's important to, and I think this case illustrates how kind of the mood, the anxiety, those sorts of issues are probably driving a lot of the patient's experience. That doesn't mean that it's all in their head. I don't want to imply that at all. These are real experiences for the patient, but it's part of our job as neuropsychologists to help patients and providers understand what's driving it. And so for some of the post-COVID patients, that is definitely driving this. And so that's something that still needs to be teased out, but it is there.
I just want to add to that such important point that I had a very similar recent patient who was unable to complete her dissertation because, and very similar, it could have been the same patient that you're describing. And the objective testing was really an intervention in her case because she needed to hear objectively that she was okay. And that calmed her anxiety enough to be able to function. So it actually can be very useful for many reasons to have that objective test data.
Yeah, it turned out, I think it was helpful, although my patient pushed back quite a bit on the lack of findings, but we talked through it, did a lot of psychoeducation around that. So,
Dr. Hunt has some audience response questions, which I think will be interesting. You may add to the discussion as well. Rick, do you want to go ahead and go?
Yeah, let's go ahead. Yeah, thanks, Jeff. I echo what's in the chat. I mean, these have been great presentations about something we hadn't quite figured out yet, and that's a hard thing to do. So really nice job. So while Echo puts up these polling questions, if the presenters could take a look in the chat, there are a few questions in there. If you could go ahead and take a stab at answering some of those, that'd help move things along for us. Obviously people have read the question already and responding. I'm not going to reread it again. The one thing that would help a lot is people really jumping on these quickly, just to like move through. And also your participation really does help, because if you have like 20 people respond when we have like 190 people on, it just doesn't give us a good feel for what's going on, and everybody benefits from seeing these results in real time. 43% voted already. Another 5 seconds. All right, let's go ahead and stop there. 55% of you voted, and that's pretty diverse response. I'll let everyone take a look. That's really diverse, Jeff. Gosh.
Yep.
Looks like 20% either strongly agreed or agreed that there were specialists who developed some experience in caring for these patients. Next. There are 5 of these total, so this is not going to go on long, but if you could like jump on these, it'd be great. Successful management strategies that improve outcomes in brain fog patients have been identified. And by the way, panelists and speakers, you don't get to respond, so you're going to see everybody else's thoughts on this. Another 5 seconds, 55% of you voted already. That's great, and really appreciate the responsiveness. All right, let's stop there. And the most frequent response was don't know. Leave that up for a couple of seconds, please. All right, next. I refer most COVID-19 brain fog patients to there's one qualifier in there, and I know you're scanning and trying to respond real quickly, so I appreciate it, but there's one qualifier in there, tertiary care medical center that doesn't have a defined COVID clinic. Okay, so I tried to get it like, be as specific as I could with this. And I think, I mean, you know, listen to the discussion, you know, at least in my view, we probably have the world's experts on this, on these rounds in terms of like experience with it. And I think about that primary care doctor who might be listening, or an EMT in Alaska that's listening, like, so what do I do about patients that I see with the brain fog? And I think that's hard for all of us right now. Let's stop there. 58% voted. Thank you. Let everybody see these results for a minute, or less than a minute. The predominant response was primary care physician. But it actually,
Harry,
yeah, go ahead.
Harry, that gets to it gets to Harry's question as well. It sounds like primary care neurology, that's where people are primarily thinking.
Yeah, and that, hey, Jeff, see that it's interesting that at least we've got some people like saying COVID-19 clinic. So there's some, I mean, okay, 6 people, but still there's some activity there, which I'm not sure would have been there even 2 months ago. Next. COVID-19 patients in my region have to travel approximately what distance for assessment and management of brain fog? And there's one response in here, potential response, use telemedicine exclusively, okay? And thanks to Echo indicating there's just one more after this, and then I'll turn it back over to you, Jeff. And, you know, speaking to, I can't remember, Karen, it might've been you, the issue of how this accessibility of patients and the telemedicine use and so forth, so on. We had one rounds that was on the long haul patients where because of some of the telemedicine rules, people were like having to travel like 4 hours to get to a center for their assessment. That's tragic. All right, let's stop there. 57% voted. And there are a lot of 101 to 200 miles there. And one individual indicated use telemedicine exclusively. Next. And I think the last. Yeah. I believe that today, patients with COVID-19 brain fog will have the best outcomes when cared for by I can't recall who talked about it, like the single point. I think it was Neha. You were talking about like the single physician thing. It reminds me in medical school when we were talking about cancer care. And it's like, you know, you need the doctor in charge of all the doctors working through this. And to me, that's going to be critical in moving this forward. That's my own personal bias with it, but wow, the coordination is just, it's a daunting challenge. All right, let's stop there. 55% voted, and wow, look at that. Fascinating.
People want to go to you guys. You guys are the ones people want to see.
Jeff, we definitely biased this one, didn't we? back.
Absolutely.
Yeah, keep that up for just another like 5 seconds, Echo, and then take it down, and then back to Jeff. Jeff, to you, please.
So I looked through the chat. Rick, if it's okay with you, if we can go just a little bit long, there were two really
sure. Go.
In the chat. One of them said, topics in some ways reminds me of PTSD in the military. What do people need to do in the workplace to get back to work? And the mention was pilots and physicians or anyone else, obviously with very, positions where they may be responsible for significant, other people or for other projects. And the other one was the medicines we use for treating COVID when you're in a hospital, does that have an impact on this condition? So I think the first one, in terms of how do you get people back to work, is probably really a really very thoughtful, considered question.
It's a very, very important question for both folks who are on the front lines as well as for society as a whole. A lot of people have lost their jobs. They were either primary caregivers for their families, and if some of the economic and financial constraints that affect health directly, both the chronic medical problems that patients and their families were suffering from, as well as the consequences of COVID-19 that we've discussed. I think that makes it very, very hard. Even if resources are available, how do people gain access to some of those resources? The second piece, where new resources are being made available and folks are just not aware that this is available to them, or they do not know that the problems that they're suffering from are real and they need to seek treatment out for them. So the second piece is sort of this awareness that what you're suffering from may be a very real organic disease problem. And the third component that I think Karen and Doug pointed out quite nicely. So in a world that is suffering from the effects of the pandemic with so much uncertainty, and instead of it just being a sprint, now it's become a marathon with no end in sight, it becomes so much more difficult to wrap our heads, to take a pause and to understand what are the different things that we actually need to get back to work to function at the same level that we were functioning. And was that even the right frame of working for a lot of us? For example, we pivoted so much to technology, and there's a lot of good things that did come out in our workplaces as well, for people recognizing that burnout is a real thing and that resiliency programs are needed, different kinds of resources are needed. As an example, at our institution, they formed a new center for growth, self-growth and resilience. And this was supposed to provide like a cadre of different kinds of resources, and you can pick and choose what works for you. But when you don't know whether you're going to have a job or whether you're going to be able to go back to work the next day, just makes it a little bit harder to get people back to work. And the fourth component is meaning finding in what we're doing. And I think a lot of folks on the call have probably experienced different kinds of, have lived through different kinds of disasters that our world has experienced. And this is probably not the first pandemic that they have lived through. So finding meaning in what we're doing and knowing that we're making meaningful contributions to society and to the people whose lives matter to us and to whom we matter, I think that perhaps is one of the biggest things to want us to keep doing what we're doing and to go back to work. Those would be, I think, some of the things. Just I'll stop there, and Karen, I'll let you chime in.
Oh, that was just
Thanks,
beautiful.
Neha.
I agree entirely that's I don't think I could say it any better.
And do the therapeutics that we use have any impact on this?
Simply speaking, I would say yes. I would say yes, particularly in the hospital and in an ICU setting. And we've known a lot of this stuff even from the pre-COVID-19 era. So I think the COVID-D study highlighted this quite nicely, with over 2,000 patients, where the use of benzodiazepines had almost gone back to what we were doing about 20 years ago. So in the midst of the pandemic, as we were beginning to several hospitals, health systems were beginning to get overwhelmed. We were not able to uphold the principles of good evidence-based critical care, the A to F bundle that has so much evidence behind it, or not having the right manpower, resources to do the right thing, or trying to adapt the the known principles of critical care that work. I saw a lot of that sort of firsthand, and then taking a pause and making sure that we go back to good practices and not just try something that we read on social media or some anecdote. And I'm a huge proponent of social media for medicine, but being very thoughtful and not abandoning evidence-based medicine, and enrolling patients in clinical trials wherever possible if there are new therapeutics or new strategies that are available, as we're trying to figure out what's going to work, what's not going to work. Because the first principle of medicine is first do no harm. So while we want to save people's lives, we've also got to be very, very sure that our therapies and our efforts are not causing harm. And it is possible that some of the therapeutics, for example, hydroxychloroquine, which at the beginning of the pandemic, we weren't fully sure whether it would work, not work. It can cause a lot of different kinds of problems. So that, or benzodiazepines, keeping patients sedated for prolonged periods of times and not waking them up, or prolonged use of propofol for propofol infusion syndrome, steroids, using really high doses of steroids and causing critical illness, polymyoneuropathy, or ICU-acquired weakness, etc. So I think both, I'm speaking more from a critical care perspective, but a lot of this also kind of applies to folks who are trying to seek out over-the-counter or medications which may cause more harm than work.
Thank you, Neha. Well, Rick, I think we're almost 10 minutes past the hour, so I'm going to go ahead and turn this back to you. I want to say thank you to both Karen Blackman as well as Neha Dangayich. Wonderful presentations. You guys complimented each other so nicely, and Doug and all the other panelists. Thank you very much. Really, really appreciate it. We had a big crowd today too, so I know that there was a lot of interest and a lot of chat here. Thank you.
Yeah, thanks, Jeff, and thanks to our speakers. I've alluded to this before, but like 10 years from now, when you go to the National Archives and look at these rounds, it'll be fascinating to see how forward thinking you actually probably were. Thanks for being pioneers in something that's literally going to be an avalanche for our society. And it's like critical moving forward, no doubt about it. So to participants, especially the ones that have hung on, really appreciate the interest and your participation in the polling and in the chat. Chat's been really active, hard to keep up with it, which is that's a great problem to have. And then for our panelists, really appreciate everyone's input and participation, and to Karen and Neha, just extraordinary insights into where we are now, but how we're going to go forward with this. A lot of work to be done for sure. With that, appreciate everybody taking care of those patients out there. This is especially challenging time with where we are with a lot of unknowns, and it's really tough. So thanks for that, and take care of yourselves. Echo, thanks as always. With that, we'll see you on the next one. When I say the next one, remember, okay, so on Thursday, we're going to do the Mass Vaccination Collaborative. That'll be emergency department rounds. And next week, a single grand rounds for each of the series that will be held in this slot, Tuesdays, clinical grand rounds on COVID, and that will be on the National Special Pathogen System, the path forward. Thanks all, and we'll see you on the next one. Bye.